Good evening and welcome to Mary Washington Healthcare Facebook Live. I'm Dr. Greg Slick, and tonight we're going to be talking about robotic surgery at Mary Washington Hospital. I'm the director of the robotic surgery program and a urologist, and tonight I also have Dr. Corey Wright.
Good evening. My name is Corey Wright. I'm a general surgeon here at Mary Washington Hospital, and also will be discussing my use of the Da Vinci robot with minimally invasive surgery.
So the robotic surgery program at Mary Washington Hospital has been around for about 10 years. We recently celebrated our 10th anniversary, and Mary Washington Hospital just recently acquired the new Da Vinci X platform. And this has really revolutionized the robotic program, is allowing us to offer robotic technology and robotic procedures in fields and areas that previously we just couldn't do. Now, the robotic surgery program was started in 2007. We began the program with prostate cancer, and that really changed the way we treated prostate cancer surgically. And nowadays, we take for granted some of the benefits of robotic surgery for prostate cancer, but those benefits now are being expanded to some of the other specialties, particularly general surgery, gynecology, to name a few, and that's what we're going to talk about tonight, especially how we're using this new platform to bring those benefits to other types of surgical procedures. We'll start by giving you a little bit of history on the robotic surgery program, and this is a live event. So if you have any questions, feel free to enter them in on Facebook Live, and we'll get to them as we go. As I said before, the program has been around for about 10 years now. We've done over 1,000 cases. A robotic surgery program doesn't just pop up. It's something that has to be thought out well in advance. It took us about a year to plan for the original robotic surgery and develop the expertise and the team around it. We do lots of complicated surgeries here at Mary Washington, but robotics is very complex. There's a lot of moving parts, and there's a lot of people that are there just besides a surgeon to help with the procedure, not only the surgical skill itself, but also preparing and maintaining the robot and all of the instruments. So there's a whole team of people that were assembled and put together the robotics program in 2007, and that expertise has been now expanded upon to allow robotic surgery to be used with the new XI platform in other areas. I guess it would be a good idea to talk a little bit about what makes robotic surgery different than regular laparoscopic surgery. I mean, Dr. Wright, you do a lot of laparoscopic surgery, but what is it about robotics that makes it different?
From a general surgery perspective, in training, the robotic use became more popular and more probably about over the last 5-7 years. Initially starting out with me in training was with the gallbladders, are doing work with the stomach and whatnot, and usually in single locations where we're not very mobile, gallbladder, adrenal glands, or also the stomach work. Over the course of those years, and with the new development of technology, different platforms, the robotic surgery has expanded to do a lot more in regards of hernia work with inguinal or ventral hernias, colon, also stomach, and pretty much every part of the abdomen. From a laparoscopic perspective, it's minimally invasive. And also with robotics, it adds the other venue of giving you full wristed instruments where you can now practice with almost 7 degrees of freedom, which means your robotic arms allows you to manipulate or simulate what you would do with your hands if you were in the body yourself. In regards of the things that has helped me really expand upon and I really enjoy using it with are right now the hernias. As you mentioned before with urology, it has really cut down with our length of stays, our pain control, also with being able to do a very full, thorough mobilization and closure of the hernia defect, in addition to laying a secondary buttress or mesh in behind it to give extra support. It also has helped with our length of stays. The hernia repairs are going home sooner. They're having less pain control. And then for us as surgeons, it gives us good visualization, 3D, high definition visualization to make the operation safer and also to make them more thorough. And as you said before, the team, we have a good team here, and the team is growing, and that's also helping our program.
Right. So from in the urology world, when we used to talk to patients about trying to decide between having an open prostate surgery or a robotic prostate surgery, laparoscopy wasn't even really an option. Hardly anybody even attempted to do a laparoscopic prostatectomy. because the instruments just don't have the dexterity to perform the maneuvers necessary to actually do the surgery. And that's, I think, what you're kind of referring to with respect to the degrees of motion, of mobility with the robotic instruments. Traditional laparoscopic instruments, say a grasper or a scissor, are straight instruments. There are some that may have some angulation to them or have the option to partially angulate for a period of time, but they're not dynamic in any sense. You put it in, and pretty much you have to use them like chopsticks. The robotic instruments are wristed instruments that have gears and cables that will move the instrument to mimic the motion of the surgeon's hand. The surgeon sits in a console 8 or 10 feet away from the robot, connected by a fiber optic cable, and the surgeon places his or her hands in the sensors that pick up the surgeon's movements, and he or she will make gestures and movements inside the robotic console, and the robot will then replicate those exact movements inside the patient with the endo-wrist instruments, but in miniature. So you can perform very delicate, very precise maneuvers inside the patient that are actually pretty tough to do either laparoscopically or even with open surgery. Doing an open prostatectomy is pretty tricky. There's a lot of angles that make the surgery pretty tough, but laparoscopically it's even worse. But with a robot, you feel like you almost have an advantage. And nowadays, I do some laparoscopic surgery, but I do feel that I'm almost at a little disadvantage when I'm doing something with old-fashioned laparoscopic instruments compared to robotics. It's
I'll agree.
Yeah.
I'll agree. I'll agree. Well, especially with the cases, as you mentioned before, the hernia cases, and as we start to get more into colon work and abdominal work, the robot has 4 arms. So it's basically 2 people that you're controlling in regards of what you can use and mobilize, hold in positions, assist yourself, and you have full control over every part of the operation. From the camera, normally in laparoscopic surgery, you have an assistant holding your camera for you and assisting you with certain procedures and different motions. With the robot, you have control over all of those functions, all of those parts. So you're fully controlling and moving the tools in the area you want them to be. They will stay there, and it's very safe and very sensor oriented. But it definitely, when you go back and forth from laparoscopic to robotic, it is like you're stepping back in time in regards to visualization, and also with the tools and with the instruments. It does offer a lot of advantages to doing these big operations.
Right. The new XI system has that, the HD cameras, and it is crystal clear.
Yeah.
So what's the hardest maneuver for doing a hernia repair? I mean, is it the angles or?
Yes, the angles for a hernia repair. You're looking at a patient who's lying in front of you, and we're rounded individuals, and trying to do using a straight tool on a round object is like putting a square into a triangle on a pegboard. So the robot does allow you to work in a small space with great visualization, great visibility. The tools, the instruments, and the ports are about pinky size. So you're doing an operation that would require normally sometimes a stem to stern type incision, going through those layers from the outside in. With the robot, it allows you to work in that same location from the inside out.
Right.
For hernia repairs, the biggest advantage for me is that with normal laparoscopic surgery, that defect, that hernia, may be this big or larger. It's hard to get that closed laparoscopically with those straight chopsticks, as you mentioned before. The robot allows us to bring the pressure of the abdomen down, to then close large defects in the midline with little tension, and allows us to put a mesh to cover that and give it a second buttress. And then we can suture that whole layer closed. With laparoscopics, we had to use tacks or thumbtacks that are very painful for patients. They have lots of complaints of the pain from that. It's a good repair, but the aesthetics, the look of it is also very much more appealing to the patients when we're done.
Right, and that pain control issue is a real problem nowadays, and everyone's aware of the opioid epidemic that we're fighting right now, and where everyone's trying to make strides and do whatever they can to reduce any postoperative pain, and especially postoperative use of narcotics. I mean, what have you seen with your the change in your technique? Are you able to send patients home with less narcotic medications?
Yes. With even going from open to laparoscopic, with minimally invasive, that does offer the ability to do more through small holes. Pain is usually less, but with robotics, we've even seen in the same operation, laparoscopic versus robotic, the pain is even less than the pain that was with laparoscopics. And I've noticed I'm sending patients home with less narcotics. They're using less narcotics. That's usually the first comment they say when they come to the office post-op, is they're surprised how much better they're feeling, how much their pain is not as severe as it was before with their previous surgeries. So I think that's a large benefit for us in that area.
So it looks like we've got a question on the Facebook Live site. What have we got?
Okay. Will having surgery with the robot make my overall recovery and return to work faster?
Certainly with prostate cancer surgery, we've seen that. Patients used to spend 3 days in the hospital after radical prostatectomy, and they would have to wear a urinary catheter for 2, sometimes 3 weeks. Nowadays, patients will stay in the hospital for 23 hours. Surgery on a Tuesday, go home on a Wednesday. They usually have a catheter for about 7 or 8 days after that, and most patients are itching to get back to work, depending on what type of work they do. If it's a very strenuous job requiring a lot of physical, intense physical labor, they might want to take a little bit of extra time off just because they don't want to get a hernia from their incisions. But generally, going back to office work or those type things, it's a week or two, and that's a big difference from having a large. I don't use any narcotics during the postoperative period for the prostatectomy patients. At the most, maybe a little bit of Tylenol with codeine and Toradol. I mean, they don't get a PCA, which is one of those morphine pumps like we used to use. I mean, what about hernia surgery? Is that?
Yeah, for the hernia surgery, the recovery time or the restriction time is about the same. 4 to 6 weeks of no heavy lifting, as you were mentioning before, because you don't want to get a re-hernia after fixing a hernia. But in regards of getting the immediate recovery, it's a lot faster. Depending on the size of their hernia, it depends. But I have sent people home with large hernias that I would have kept overnight or even 3 days before for an open or laparoscopic surgery. I've sent people home on the same day because they were feeling great. They were tolerating a diet. They had very minimal pain that was manageable with minimal pain meds. And so, yes, the recovery time I've noticed is quicker. The immediate recovery time is quicker. The post-operative healing time is also quicker. Folks are up, moving around. They're getting active in regards to staying within the lines of their restrictions, of course. And overall, they're happier.
Right.
They have expressed great satisfaction for being able to get up and get around.
Now, is it the? I know when you put the mesh in, you have to secure it somehow, to the inside of the hernia. Robotically, are you doing that differently in some way that decreases the pain?
Yes, I'm putting the mesh in like I would do in open surgery with my hands, or suturing it in, as opposed to using these tacking devices, which is like a thumbtack, which we place into the hernia through the mesh into the abdominal wall, usually requiring a good bit of those tacks depending on the size of the mesh. But with the robot, I am suturing him, getting more accurate bites, more precise bites, and I'm avoiding nerves. I'm able to run those sutures continuously around that hernia, and it's been pain savings. There's been a cost savings that we're trying to prove, and which other surgeons have proven. There's actually some cost savings with that, and efficiency with getting them in and out of the hospital.
Right.
Okay, we have a couple questions about cost. So does performing robotic surgery cost more for the patient or the insurance company than traditional types of surgeries?
Yeah, there are some other costs associated with robotic surgery. The actual instruments themselves, the use of the robot, and the maintenance of the robot itself. But you also have to consider it that a patient would have possibly stayed in the hospital 2, 3, or 4 days longer previously. And so if you're looking just at instrumentation, that perhaps it may have looked more expensive, but when you look at the entire hospitalization or how long the patient actually stays in the hospital, it may actually be less. It really depends on the insurance program. The patients typically aren't seeing a big difference in their bills as from a instrument perspective, but may see actually a shorter hospital stay, which is certainly good for everybody.
Agreed.
And sometimes we're able to. There's other instruments that you use during surgery which are just as expensive as some of the robotic instruments, like those stapling devices.
Yes.
Those are sometimes, some of the ones I used to use were $500 a shot. I mean, those, and we don't use those anymore. We can do it all now with hand sewing with a robot. So.
With less ports, so you're not using more ports, less holes.
Yeah.
It's a huge benefit from that aspect.
Okay. We have another question. This is about pain management. Is robotic more or less painful than an open surgery, and is it quicker than traditional methods?
Well, I can tell you that my patients who I do the prostate surgery on are using less narcotic medications now than they were 10 years ago before we had the robot. So, and they're certainly staying in the hospital, a lot for a shorter period of time. As far as the procedure time is concerned, there is a little bit more. There's more steps involved from the very start of the procedure to the very end of the procedure with robotic surgery. So. It does take longer to do this surgery if you look at all the steps because of setting up the robot. But an efficient team like the ones we have now, whereas it would take me maybe 2 hours to do a robotic surgery, to do a traditional surgery, it might take me 3 hours to do a robotic surgery with all the steps at the beginning and the end of the case. The robotic operating surgical time is still about the same, the time that the surgeon is actually on the console, probably about the same, but there's just more steps.
I think for us in general surgery, that the exciting thing about the new XI system is the new tools it gives us.
Right.
The XI allows us to have energy devices for bleeding control and for dissection. It allows us to have stapling devices so we can do bowel and colon work. Suction devices,
all built into the robot.
All built in.
Right.
So these are all separate components that we can use at the same time of the actual operation. So you're two people in one with those new devices, right. And that has really helped us to broaden out our approach. Almost every operation we can do robotically that we couldn't do before laparoscopically for whatever reason, and the ones we could do laparoscopically, we can do them more efficiently.
Right.
There are other features that allow us to identify structures and identify other things that are always worrisome in the beginning.
So what do you think's on the horizon for general surgery? I mean, you talked about hernia, right? You guys do a lot of colon surgery, right? Is there possible application for that? Or?
Yes. There's application for colon, left, right, and middle colon. There's application for small bowel. There's applications for almost any part of the abdomen. Stomach, spleen, liver, pancreas, every component of the abdomen. If it can be done open, there's a good chance it can be done laparoscopically in the right patient, as long as they can meet the criteria for anesthesia time and for the procedure that needs to be done.
Now we were also thinking about having Dr. Scott Walker here with us tonight, but he's actually up on labor and delivery, delivering some babies right now. Those little ones sometimes don't adhere to our specific schedule. So Dr. Walker is a gynecologist, right? And so OBGYN physicians, they are also using the robot for hysterectomies, oophorectomies, and also one of my partners, Dr. Beeman, uses the robot for sacrocolpopexies, which is a surgery that's done for female pelvic prolapse and incontinence. And from a urology perspective, there's a couple of physicians in my practice that also use the robot, myself and Dr. Hill and Dr. Beeman. And we're doing prostate cancer with it. We can do bladder cancer surgeries with it. And we also do removal of certain kidney tumors and reconstructive surgeries in the area of the kidney called a pyeloplasty. That's when there's an obstruction in the ureter, which causes there to be a blockage trapping the urine up in the kidney, and we can surgically repair that. And that procedure, very tough to do laparoscopically. It takes long hours and hours to do laparoscopically because you're trying to sew with very primitive instruments. Is a great quick procedure now with the robot, and we hardly ever do any of those open anymore. Those are all now done robotically. So.
And for general surgery, we have myself, Drs. Brad Ryan and Brad King also doing robotic surgery from a general surgery perspective. And, you know, who know, our program is growing. I think general surgery was probably the last ones to get on the train of robotic surgery following urology and gynecology.
Yeah, we've got Dr. Patel.
She's also involved with robotics. And I think we've nationwide, I think robotics has really taken off. I think on a general surgery standpoint, it has really blown up in our programs and training programs to do more of colon work, small bowel work, hernia work, getting to areas of low rectal cancers and rectal cases, being able to work in small spaces very effectively and efficiently also has helped us from a general surgery perspective.
Now, this new robot, the XI, has some other cool features, and one of them is the Firefly, which is sort of an infrared visualization camera built into the robot. The patient is administered a special dye, and that dye will fluoresce, allowing you to see blood vessels that you either want to identify or perhaps avoid during surgery, and that's actually pretty useful when we do partial nephrectomies for kidney cancer. And I think with bowel work too, bowel resection, you need to see the vasculature very accurately.
For bowel surgery, definitely for looking at vasculature.
Right.
If we're in the pelvis, it also helps us identify the ureters, so, which is, you know, in your world also, but we're also working in that area down near in the pelvis where the kidney and the bladders connect, the tubes connect, the ureters connects those two organs together. That allows us to work safely down there without causing any injury. And in the upper abdomen, it also helps with liver, pancreas, and gallbladder work. It allows us to visualize the bile ducts with that same dye as it filters through the liver. It gives that bright reflection to allow us to help identify structures that could be visible in the very tough or difficult gallbladders.
Right. Yeah, we didn't have that before. That's one of the new. We got another question.
How do patients qualify for robotic surgery? Do they seek out the doctor that does this, or are they referred, or both?
Well, the patients generally, usually as part of the evaluation process, depending on what type of process is being treated, the surgeon will either refer the patient to a surgeon who has robotic training, or if that discussion is happening, I guess, with someone who already has robotic training, typically there's an evaluation process to see if it's going to be a good fit. You know, not all patients are good candidates for laparoscopy, and not all patients are good candidates for robotic surgery. But the vast majority, well, I can speak from a urology perspective. The vast majority of patients who are going to be undergoing prostate surgery, for example, for cancer, are going to be having it done robotically, and this is a really good reason. And some of the reasons why it might make it more challenging would include if the patient is very heavy, if they have a very large abdomen. Sometimes the positioning during surgery, which requires the patient to be put in a kind of an upside down tilted position, makes it a little difficult for the anesthesiologist to adequately ventilate the lungs if the belly is too big. And there's some patients that there's a little bit of a restriction due to their size. And other patients, if they've had prior abdominal surgeries with a lot of mesh in there, that makes the approach or getting into the belly a little bit more treacherous. But now with the new robot and now that we have general surgeons that are using the robot alongside the urologist, we'll often do a combined surgical procedure. So now that we have more advanced technology and also more skilled surgeons in the area, we've done a few of those more complicated cases without any trouble. So that's there's really only a few contraindications to robotic surgery. I mean, from your perspective, what would be? I
think, like we are, as you said before, the robot's a tool. Like any tool craftsman, it's a tool in their toolbox, and it has to be used on the right patient at the right time. So I fully agree with that. You know, every patient is specific to the procedure and the type of surgery they need. But in the pre-op evaluation, that's what's discussed. If they are able to undergo the anesthesia, the length of the procedure, the positioning of the patient also plays a factor, and other health issues that may or may not be present. But yes, every patient is different, but we do try to make it tailored to their efforts.
And even like the size if you're operating on a tumor, simply the size of the tumor may be a reason why, if you're going to have to make an incision this big to get the tumor out of the body anyways, then you're probably going to do it with an open incision.
Correct.
Right? So,
yep.
So common sense plays a role too.
Another question?
So can you tell us a little bit about how the new XI robot is different from the one you've been working with for the last 10 years?
Right. So The major changes have occurred both in the visualization system with the high-def new full HD cameras, but also in the arms that are actually holding the instruments at the bedside. That's called the patient cart. The surgical console where the surgeon sits is where all the fancy cameras and the hand sensors are. But the patient cart is at the bedside, and that has really undergone a full makeover with the new XI system. One of the big things, the big limitations of the old system was the arms were very thick and clunky. And if you were trying to move from one section of the abdomen to sort of go take a look or do some area, the machine couldn't make that transition. It couldn't flip and move in that direction. The new robot is completely suspended on a boom, and when it pulls over the patient, it can rotate and move around, and you can access multiple quadrants of the abdomen at the same time. And that's what's really making your surgery possible.
Definitely,
right? I mean,
definitely. A lot of our surgeries are dynamic.
Right.
We're in multiple parts of the abdomen. Like you said, the patient cart and the boom system does allow us to work on both sides of the patient's body, top or bottom, or in all quadrants at the same time. Before, if we were to try to do that, we would have to disconnect the patient from the robot, remove it, reposition, reinsert, and that takes a lot of time, involvement, and also makes it more of a less efficient operation.
Right.
So I think that definitely the new technology has aided a lot in that to allow us to work more efficiently.
And with the old robot, once you have a patient into a position, you couldn't tilt or move the table at all without completely undocking the robot. But now the new surgical table that we have actually is paired to the robot. So if you need to tilt the patient and move the patient a little in a certain direction, the robot will actually move with the table. It's pretty cool, actually.
It's cool.
The new robot also has a number of other instruments that actually are built in: stapling devices, energy devices. The Firefly, luminescence visualization platform, the suction devices, right? I mean, those things we just didn't have before, and that allows us to be a lot more efficient too. You can rotate the camera angles all automatically with the new robot.
Different ports the robot allows us to put the camera in different ports on the patient so we can see the same anatomy from different angles.
Right.
That also aids in the safety of the operation and gives us better visualization to do more intricate dissection. So I think this new platform is amazing.
Yep. All right. Looks like that's about all the time we got this evening. So wait, one more
question.
All right. Well, thanks very much, Dr.
Thank you.
Wright. Thanks
Thank
for
you.
joining us. See you in the OR.
See you in the OR.
All right. Good night, everybody.